I'm going to talk a little bit about some things we're doing at the NIH. When John initially approached me and asked me to come up to visit you at Teachers College, I think he wanted me to talk a little bit about some of our new strategic directions, which I'm going to do. And then I want to talk in a little bit more detail about something that we sponsored recently that's come out within the last month or so about international comparisons in health outcomes. And it's something that's really gotten my attention and I think helps us refocus how we want to look at things in the future. So that's all to come. But before I want to do this, before I do that, I want to ask you this question. What is the name of the government agency that funds most of the medical research paid for by taxpayers in our country? Anybody know? NIH. Well, it turns out that it is the NIH, but less than 10% of people in our country are able to identify this question that was in a Gallup poll. And about an equal number of people identified Harvard University as the, as the government agency that funds most medical research paid for by taxpayers in our country. Actually, more people identified CDC than NIH. And CDC is a great organization and it does wonderful work, but in terms of investigator-initiated grants, it funds about 1/6 of what the NIH does. And here's the most interesting one. Almost as many people, about 5%, identified private drug companies as the government agency that funded most research paid for by taxpayers. So we have some work to do. Now, part of the problem is this, that we are a conglomeration of 27 institutes and centers. And here are all the logos for these 27 institutes and centers. So part of the difficulty is that when people read about research in the newspaper, they think of these institutes, the National Institute of Diabetes, Digestive and Kidney Diseases, NIDDK, or NIMH, the National Institutes of Mental Health. So, in fact, I had a meeting with a member of Congress a couple months ago, and as I was walking out, he said, by the way, he said, is the National Cancer Institute part of the NIH? So part of our difficulty is that the identity is not with the overall NIH, but rather with the institutes. And to give you a sense of how bad this problem is, I'm just going to show you a very small, this is a very, very small subset of the official logos that are approved within the National Heart, Lung, and Blood Institute. So, in fact, there are many, many more, and these are approved logos. So there are a lot of logos that are not approved. And so when people read about research in the newspaper, they think of the ERIC study or the SMART study and so forth. So you will see over the next month or so our rebranding. So like any other product, the NIH is rebranding itself. And last week we introduced a new logo. This is not exactly it actually, but you'll see it very soon. So we're going to the NIH branding. And you'll see these big letters that say NIH, maybe there's a pointer here. And then it will have in smaller letters the names of the institutes. And the message that I'm always sent out to deliver to groups that I talk to is never forget to mention your grant and your publications, because that actually is the most crucial part of the communication that is read when members of Congress read the New York Times. We want them to say this grant was funded by the National Institutes of Health. And actually, one of the big issues, just as a diversion, a lot of times the problem is within public affairs offices within universities. So they'll say, this study funded by the University of Missouri, but we'll never mention that the University of Missouri was funded by the NIH. And we think that this is actually crucial in terms of our budgets and what happens in our funding cycles. So look for clear rebranding. It's coming, and pretty soon all these logos, like this one you see here, we refer to this as the coat hanger. Let's see if I can get this. The coat hanger is going to die. Actually, it's literally etched in stone at the NIH in various buildings, but it's going away. So the NIH, as you probably know, has a very simple organizational structure. It looks sort of like this. So these are the 27 institutes and centers. The ones in yellow only fund extramural grants, and the ones in pink don't fund. Those are information technology and the Center for Scientific Review and so forth. And within the NIH, there is an office. There are 4 substantive area offices. So we're the Office of Behavioral and Social Sciences Research, There's an Office of Research in Women's Health, an Office of AIDS Research, and an Office of Disease Prevention. And each of the heads of those offices is one of the associate directors that reports to the director. And our goal is to coordinate research activity across these 27 institutes and centers. Very soon, we're going to have a new office, the Office of Data Science. And that director will also be one of the associate directors. Now, one of the topics that I wanted to mention is that if you look at how we talk about our health objectives for the years 2000, 2010, 2020, I know John has worked on this and written about this. We have very general overall objectives. And a lot of people don't realize this, but these are Department of Health and Human Service wide. So the overall objective, the first overall objective for the year 2000, these were developed in the year 1990, was to increase the span of healthy life, or the quality adjusted life expectancy, we call it, for the US population. Or the number one overall objective for the year 2010 was to increase the quality in years of life for the US population. And now in 2020, it's a little bit more complicated. There are 4 overall goals to promote quality of life, healthy development, healthy behaviors across the lifespan. So I just wanted to emphasize that these are our departmental objectives in the Department of Health and Human Services. But it's not always recognized across all the things that an organization like the NIH does. So if you look at the NIH Mission Statement, which I like to come back to because I think it reinforces this point, the overall objective is science in pursuit of fundamental knowledge about the nature and the behavior of living systems. But there's a second clause, and the second clause is, and the application of that knowledge to extend healthy life and reduce the burdens of illness and disability. And so I'm not sure that all of my NIH colleagues really recognize this, but a big portion of what we're attempting to do in our mission at the NIH is to get people to live longer and healthier lives. And that all the different things that we do in biomedical and behavioral research should be oriented toward this general objective. Now, in order to do this, we have 3 overarching objectives in the Office of Behavioral and Social Sciences Research. And when I came to the NIH, I had a meeting with Francis Collins, who's the director, and I came in and I had about 70 slides with all the things I wanted to do. And he sort of stopped me about a third of the way through, and he said, you can have 3 things. 5 is too many, 2 is too few, 3. And so these are the 3 that we came up with. The first one is planning for the next generation of data and data analysis. And the second one is delivering services in a reforming healthcare system. And the third is the next generation of education and training the future investigators. And so I'm not going to spend a lot of time on these today, but I just wanted to introduce you to these before I got on to this other major topic. So the first one has to do with the next generation of data and analysis. And within this category, we've become very intrigued by this evolution in the way that we gather data, analyze data, and present data. And we think that we're going to go through a major transformation in the next decade or so. So one of the areas we've become very interested in is mobile health technologies. I think all of us carry cell phones, but also there's sensors. There are all kinds of other things, and I'll show you some of that in just a minute. The availability of electronic health records, which will provide platforms because they have data, and more data than we've ever had before. System science, and then these masses of data that we'll have that we just don't know what to do with. Most of us weren't trained to deal with this. Data visualization and these new methods of analysis. So as a way to introduce this, some of the work we're doing on mHealth technologies I think is particularly interesting. Unfortunately, John had asked me to come on Thursday of this week, and it turned out that Thursday of this week we're having what we call the mThink Summit, where Director Collins is having a variety of major leaders from the electronics industry come to the NIH to talk about how we can interface with them. And one of the issues has to do with, well, how we're going to do things in research that we've never been able to do before, but we'll be able to do them now because we have these electronic devices available to us. You know, everything in the NIH has something to do with omics. So there's genomics, and there's proteomics, and there's metabolomics, and so forth. And so we thought we needed our own term, and so we call this exposomics. And as you know, as we go through our lives, we're exposed to risks associated with foods, physical activity, medicines, over here, alcoholic beverages, effects of poverty, frightening experiences, pollution, and so forth. And one of the things we've come to realize is that there has been this revolution in genetics, so that the coding of the human genome is just a little bit more than a decade old now, where the unraveling of the genome was made public for the first time. Really quite a stunning scientific accomplishment. But what's happened in the last 10 years is that coding the genome has become much less expensive. So there's Moore's law in electronics, where you can do twice as much for half the price. A chip that's twice as powerful for half the price. Well, the acceleration in genetics is actually much more rapid than Moore's law. So now, coding the genome is actually the easy part. And so within a few years, for less than $1,000, you'll be able to code the genome on just about any one of us. In fact, there's a New York Times story about this morning. So now we realize that this is the easy part. And of course, putting aside epigenetic phenomena, the genome is pretty straightforward. It's relatively static from conception to death, and there are these new technologies and it can be done. The hard part is actually coding exposures. So we know that the combination of genetic exposures and environmental exposures ultimately is going to determine what happens to us. So as we study this nature-nurture problem, what used to be the hard part, studying the nature part, we now think is the easy part. The hard part is in coding what happens to people over the course of time, because this is dynamic. We have exposures throughout our lifetimes, in utero, in adolescence, in adulthood, and so forth. But we think the game is changing because there are billions of mobile devices. There are almost as many as there are people in the world. There are about 6 billion mobile devices currently. There are billions of sensors. Billions of people are using social networks. And so we can do all sorts of things that we could never do before. So the opportunity to capture data in all kinds of environments, to code things, to have continuous streams of data is really quite remarkable. And it's just getting better and better and better. Our problem is we just don't know what to do with it all. So we don't have the analytic methodologies. We don't know how to store it. We don't know how to give absolute assurance of privacy protection and so forth. And that creates all kinds of new challenges that will involve all sorts of new collaborations with the engineering community and others. So let me give you just a couple examples of some of the things that we've been attending to. We've always been interested in the public health world in coding dietary exposures. And so if you look at this work, that you can take a cell phone, and this is an Apple iPhone application, and take a picture of this plate of food, and from this estimate the proteins, carbohydrate, and fat. Now I think that some of you know this work. The problem is that it's not perfect. We know that it's a long way from perfect. But by the way, compare it to the error in 24-hour diet recalls and so forth, it actually is coming along. But what we've really learned is engineers iterate things. And so that within a very short period of time, just look on your iPhone and look at the little red circle with all the new updates of these applications. In a relatively short period of time, these are going to be much better. We know that the ball is really in play with this improvement. This is a really interesting application. This work comes from David Bansberg at Boston City Hospital. And you see this woman here who's holding this little box. Unfortunately, this woman is in Uganda and she's infected with HIV. But at a certain time of day, she takes a very complicated regimen of multiple pills. But at a certain time of day, that box beeps, and then it opens, and it dispenses the medications she's supposed to take at that time. And the box records her adherence. And so over here, you can see her adherence record on that day. So when Dr. Bansberg came to the NIH to present this work, with this woman's permission, of course, he was able to say, here I am at the NIH, here she is in Uganda, and here's her adherence record today. This is a static slide, but when he presented it, it was her adherence record the very day that he was giving this presentation. So these devices communicate all over the world. We have tons of examples of these, and we think that there's a remarkable opportunity for all kinds of new research. The problem is that much of this research is not well evaluated. So there's lots of trials. We recently reviewed them. We found that of the experimental trials for behavioral intervention, less than half of them showed that the devices really were doing what they were supposed to in terms of behavior change. So there's remarkable potential, but also remarkable need to develop research in this area. We also think that in order to do this work, again, we're going to have so much data, again, continuous feeds. That woman's data is going to be coming in continuously day after day, that we need new ways of thinking about this. So one of the areas that we feel we need to get into is the idea of data visualization. How do you take hundreds of millions of data points, digest them, analyze them, and present them in a way that's meaningful? So this, I think many of you have seen before, but this represents the size of continents, but instead of using land mass for the size, we use the number of people infected with HIV. And here you can see that the African continent is very distorted. If you look at the South American continent, for example, it's very tiny, suggesting that the HIV threat, at least currently in Latin America, or South America, is much smaller, and of course overemphasized here. U.S. is actually smaller than its land mass, where Asia is a little bit larger. One of the really interesting examples is the use of system science. So we have in our group, we have a group of people now working on system science. We had a bunch of program announcements in this area, and I think this is really fascinating. What I'll do is I'll get this started for me to talk about it. Let's see if I can get my pointer to work here. So what you'll see, and I'll have to speed it up to get it going, is you see the simulation of two adjacent communities. And these communities, in this hypothetical example, are households of 4 people. And then each day, the people will leave their households and they'll go to either work or school. And the question is, how fast, in this case, does the smallpox epidemic spread? This work is done by Josh Epstein at Johns Hopkins. And so you can see how people going to school and work start spreading these cases. So these are people over here entering the hospital, and these are people entering the morgue. And so let me just move this ahead some, so I'll advance it. So you can see that over the course of time then, we start getting many, many more cases as the people go back and forth, and of course many deaths and many more people in the hospital. So these techniques, although quite imperfect, allow you to experiment with all sorts of different things, all sorts of different ways, like closing the schools, closing workplaces, blocking the roads between the communities, and so forth. This one, I think John mentioned that I spent time at UCLA. This is sort of an interesting one. So what you see here is Los Angeles, and what we're going to show you is this 3D model of LA, and we'll show you a toxic gas plume exposure. This has to do with people traveling in Los Angeles. You'll see the pink plume coming up in the background, and then the blue are people going on the LA freeways. And what's going to happen soon is those freeways are going to lock up, and then you'll start seeing little pink dots of people leaving their cars or workplaces and running, and giving themselves much greater exposure to this toxic substance that's being spread out over Los Angeles. So what does simulation do? Well, it allows you to experiment with lots of different public policy options, closing the roads, prospective planning, and what you would do under one of these circumstances. Now, one of the examples, I think that's a very interesting one, it's being done by a person named Holly Jemison, who's working in our office, is on an IPA from the Oregon Health Sciences University. It has to do with using these technologies to understand people's living spaces. And so here we have an accommodation for somebody that's elderly. And so you can see the different rooms in this place. And here you can see these sensors. And these sensors, by the way, are remarkably cheap. I mean, you might have them in your home in a burglar alarm. What I was shocked by was how little they charge you a fair amount commercially, but how little these cost. And so these sensors can detect movement. And also you can put 3 of them together in a hallway and use them to time movement. So physical activity studies, for example, you can determine how fast somebody's walking down a hallway. You can determine whether or not their gait changes and so forth. So the question is, now you've got, say, a person living by themselves in this place, feeding you data constantly, and what do you do with all that data? So this is one of these data visualization techniques, which I find to be really interesting. So what you see here is a year, and so each circle in this year represents one day in this person's life. And so this is the first day, this is the 365th day, and so you can determine how much movement there is in these various parts of the home. So you can determine that between midnight and about 7 in the morning, the person is spending almost all their time in the bedroom. The first part of the year they're sleeping well, at least they're not getting out of bed, and then something happens here where this person is getting out of bed frequently at different times. These are the occupancies of the kitchen. You can see them changing with different meal times over the course of time. So a tremendous amount of information can be summarized with this very clever use. And we see this sort of creativity as being something that really has great importance for us understanding things. So how do I summarize what we're doing in this area? Well, we're very interested in the data of the future. We've become increasingly interested in harmonized tools, these promise measures, which you're probably familiar with. The NIH has recently released the Toolbox, which is a whole series of measures that are public domain, free of cost, well validated, that can be used in studies, that will allow us all to collect similar data if we're interested in doing that. Use of electronic health records, harmonization of the elements within those for comparison across studies, that will create these big databases that people will be able to use. We also are very interested in these mHealth technologies, visualization, and then this next generation of analytic techniques, because so many of us, like me, were taught to use statistical technologies that were developed for agronomy in the 1930s. But it's not that relevant any longer. If you have hundreds of millions of data points, doing the t-test doesn't help you that much. So new techniques in data mining, pattern recognition, and so on. So I'd like to take most of the rest of my time today to talk about something that really has caught my attention more recently. This has to do more broadly with the determinants of health. We know that they're affected by medical care, by personal behavior, but also by all kinds of other things, living and working conditions, economic and social factors, public policies that promote child development, and so on. And if I get back to that NIH definition of the second clause being that using knowledge to get people to live longer and healthier lives, I can't help but think that it's part of our obligation to learn a little bit more about these things, even though I do have to say that many of my colleagues at the NIH might not recognize this as part of our overall mission. So one of the areas that we're going to be spending a lot of time on is learning about these determinants. By the way, I think it is worth putting this up. This is the WHO conceptualization of health. And I only show this because that in their conceptualization, the healthcare system is a tiny box. It's there, it's a box. But it's a relatively small box in the whole picture, where I think in the United States we think of the healthcare system as the biggest box. So our second theme that we're working on is this notion of understanding the determinants of population health and sort of health outcomes in this era of healthcare reform. What are the major determinants? How can our investments have an impact on this? Now, when you look at the NIH, the sort of official NIH position is this, that the NIH has had a big impact on the life expectancy. So, for example, there's been a reduction in cardiovascular disease mortality, really quite a stunning accomplishment in the last century. HIV rates have gone down, allowing people to live into their 70s. Cancer rates are falling. And all this is good for the economy. And that the message here is that life expectancies in the United States are getting longer, and we're really doing well. But in fact, if you probe this a little bit more, there are some problems. For example, this is what really got our group particularly interested in this. This comes from a National Research Council study that was published in 2010. And to summarize this, it shows that life expectancy in all these developed countries is increasing. But this bright red line is women in the United States. And so it looks at this issue of what we call current life expectancy for 50-year-olds. So if you reach age 50, how many years of life do you have left on average? In 1955, we were doing really well in the United States. We were 12th in the world. So we weren't number one, but 12th is good. Now we're pretty close to 50th in the world. So that it is true that our life expectancies have increased, but the rate at which they've increased is considerably slower than it is in these other developed countries. So we funded another study, and this is one that our group had a fair amount of involvement with. This was a National Academy study, and in this particular study, we asked the academies to look at health outcomes, life expectancy, and morbidity in the United States in relation to peer countries. So we weren't really dealing with the developing world, but these are peer economies. And these are the economies that we looked at for comparisons. The United States is the bottom one. So they're primarily Western European countries, but it also included Canada, Japan, and Australia. By the way, it's sort of hard to choose these countries. The reasons, like Belgium, for example, is not in the comparison. Not because they're not a peer economy, but because their data sources that were available for analysis weren't as good as they were in these countries. So they had to have the right data, but also to be economic competitors. Well, the result of this study, and so I'll give you the punchline, but I'm going to go over it over and over and over again. The result is we're doing badly, surprisingly badly. So, for example, if you look at mortality from non-communicable diseases, we are 16th out of 17 peer countries. Denmark does more poorly than we do, largely because that women smoke cigarettes like mad in Denmark, although they're stopping. If we look at mortality from infectious diseases, we're 4th from the bottom. So 3 countries do more poorly than we do, Portugal, Japan, and the United Kingdom. But in certain areas, we're doing terribly, and in particular HIV, where we lead HIV in the Organization of Economic Cooperation and Development. Our rate is 9 times the average of the other countries in the developed world. Mortality from injuries, we're 2nd to the bottom. Finland does a little bit worse than we do, but we are doing quite badly. So we had the highest death rate from transportation-related injuries, and I'm going to come back to that one in just a while. And by the way, a lot of people will say, oh, well, it's only because we drive more. But in fact, these analyses control for miles driven. You can see that the solid line represents the mean of the other countries, and the dashed line represents the United States. So we started lower, but our rate of decline has been slower, so that now the other countries have crossed, and we are doing more poorly. Now, one of the items that has been in the news a lot lately, I think in Washington is still controversial, maybe not controversial to all of you, is mortality associated with civilian use or civilian possession of firearms. We're about 69, firearms are associated with about 69% of our homicides in the United States, and we have the highest homicide rate. It's about 7 times more likely in a homicide that people will be killed using a firearm in the United States than in the other countries. And suicide, interestingly, we're doing relatively well in suicide. So our suicide rate is actually on the lower end among these countries. But among the suicides in the United States, we're about 6 times more likely to use firearms in these suicides. So if you look at life expectancy from birth in the United States and the other countries, men, we actually are at the bottom. We have the shortest life expectancy of these 17 countries. Women were 2nd to the bottom. Again, Denmark does more poorly, largely attributable to tobacco use. So I am going to switch gears a little bit because the opportunity to come to Teachers College, where there's a lot of emphasis on young people, gives me the opportunity to talk a little bit more about what happens in early life. And I hope we have enough time for discussion. If we don't, I'm going to stop so I hear the discussion, because I really would like to get some feedback on the early life issues. So one of the issues is if you look at life expectancy from birth in these countries, you can see for men we were toward the bottom in 1980. And by the way, 1965 we were up toward the high end. We switched down there. For women, we were pretty close to the center of the distribution in 1980, and now you can see we've gone to second to the bottom. But if you look at probability of survival to your 50th birthday, this is the big surprise in this study that no one was really talking about before. So it's before everyone was talking about if you reach age 50, how many more years do you have left? But this gets at what's the chance you even make it to 50? What's the chance you actually, I'm going to talk in a little bit about what's the chances you make it to age 5? So you can see that men, we weren't doing that well, and now we end up at the bottom. For women, we've gone off the scale. I mean, really quite shocking. So that we're no longer even comparable to the next closest country. So if you look at years of life lost before age 50, we are absolutely the bottom in this set of comparisons. Now, one of the things that's interesting is if you do the rank order by age, so you'd say, so what this graph shows you is out of 17 countries, what's our rank? And this is the age spectrum. So, our infant mortality is the highest. And then it sometimes goes to 16th, but it's usually 16th out of 17th. Until we reach age 75, which was the real shock. At age 75, we actually go up toward the top. So if you make it, if you're not dead by age 70 or 75, we do much better in the United States than these other countries. Now, one of the things that people keep bringing up is they say, well, this is because of our ethnic diversity, because of our income stratification, and so forth. One of the real surprises in this set of analyses is that actually if you take non-white Hispanics, non-Hispanic whites, this is the slide I just showed you. It looks surprisingly similar. And actually, people with good health habits in the United States, so high-income people with good health habits, if you compare them to comparable people in these other countries, we still come out close to the bottom. So morbidity, very similar story, but sometimes even worse. I think none of you need to be persuaded. I think you've heard this a jillion times before, but we absolutely lead the world in obesity and calorie consumption. No one's close to us. If we look at diabetes, at most the age spectrum, Spain does a little bit worse, but we're very close to the bottom. And again, I wanted to sort of get into the kid stuff. Infant mortality, of course, we are the worst in these comparisons. And it is worth saying that our infant mortality has been coming down in the United States. Between 1990 and 2010, it went down 20%. So that's a very good accomplishment. But it went down 50% in these comparison countries. So we're doing well, but other countries are doing better. And you can see now that although we started a little bit lower, we are now higher. Birth outcomes, perinatal mortality, preterm births, we still are doing considerably worse than these other countries, second to the bottom. The probability of dying before age 5. Again, the United States has the highest rate of deaths associated with negligence, maltreatment, physical abuse. The rate of violent deaths for U.S. boys age 1 to 4 exceeds the average and has, by the way, this is not a new trend. This has been there for a while. About 11% of these early deaths are associated with injuries and many cases preventable injuries. Adolescent health. Adolescent health, again, we are doing quite poorly, so that there is a strong adolescent health disadvantage. And one of the things that emerged in this report is, then when you look at the data, this didn't just happen. This has been building up for decades. And I think a lot of you are nodding your head because you work in these areas, but in fact, this has been going on for a long time without enough public attention to it. Teen pregnancy, pregnancy before age 16 was the indicator used in the study. About 3.5 times higher than the average of the peer countries. We do more poorly. Teen STDs, we lead these countries, and HIV prevalence in the 15 to 24 age bracket. Of course, we lead these countries by some substantial margin. Adolescent injuries. Again, we have always been higher, period where we were getting better, which is right in here. And then these curves seem to have diverged again. When we look at youth-related deaths from violence, you can see the sort of grayish line is the other countries, the median, and the red line is the United States. We had a peak a few years ago and it's gone down some. Nevertheless, we still lead in this indicator by quite some substantial margin. So males aged 15 to 19 are 5 times more likely to die in violence than the average of these OECD countries. Adolescent health disadvantage, showed this already. So we get back to the adults, just sort of moving toward a summary of the problem. If you look at those people above age 50, there is no one cause. And when people hear this, they want to say, oh, well, it's because our cancer rate is higher or a certain. Actually, it turns out it's all kinds of different things. So it's not, you can't put your finger on any one thing. And there actually is some good news in the United States. We do well in some areas, like cancer mortality is going down and going down more rapidly in the U.S., stroke mortality. The U.S. does really well in controlling blood pressure and cholesterol. Our sides actually are lower, elderly survival, and actually we self-rate our health to be higher, interestingly, in the United States. But there are these disadvantages. So Americans die younger. I really want to make the point that this is not new. So all of this is based on data sets that have been established for a while. They're based on published reports that have been in the literature for some time, although there's sort of a crescendo of them coming in the last couple of years. Is the emphasis on young people. So that the emphasis on the earlier reports was life expectancy. And what's really emerged is an awful lot of this has to do with making it to your 50th birthday, getting to the celebration of the 50th birthday and the 5th birthday. And that's where we seem to be doing poorly. It's also important to point out that this is not a problem that's exclusive to people of lower socioeconomic status. In fact, it affects a variety of different income and education levels. So, a couple minutes on, hopefully I'll be able to wrap this up in a few more minutes, but I would just want to talk about, well, how do we explain all this? What is that accounts for this? Well, the first thing that people want to point their finger at is we have a really crummy healthcare system. I don't know if you agree with this, but some people feel, I guess as a government official I can't say this, some people feel that we have a less than optimal healthcare system in the United States. And so because that we have a crummy healthcare system, we have a lot of people who are uninsured. And I think that is probably part of it. So we definitely have fewer people seeing a primary care physician. We overspend in relation to other countries. We overtreat, overtest, using resources perhaps not wisely. But we do some good things. We're good at cancer screening. We're very good at controlling blood pressure and cholesterol, at least in relation to other countries. The NIH actually has just released a document saying that they want to invest more. What they said is, we're going to take seriously this problem of 50% of people going into work that is not directly related to being a professor. Or they want to encourage training to prepare people for a wider range of activities. And they also say that we want to take this notion of team science seriously. Now, the question is, how do you take it seriously? And so I'm going to give you a longer answer than you. I hope you'll bear with me. So I'm going to sort of hit a couple things in this answer because your question is such a good one. So one of the big issues is, I go around to a lot of campuses and talk to people, and sometimes I'm fortunate enough, like John, to meet with a provost or a vice president for research. And I always ask this question. I haven't had a chance to ask John yet, but I say, what is your university doing about team science? And what I always get is, this university is the leader in team science. We're the ones that are way ahead. We're ahead of the curve in this. And then the second question I ask is, how are you doing at getting your faculty promoted who do team science? And they kind of groan and they say, oh, well, that's the faculty's problem. Faculty promotions are based on, faculty peer recommendations, and we in the administration are behind this. It's the faculty that won't recognize team contributions. And so, and I know this from when I was at UCLA, we had, I thought, a really good program that was a multidisciplinary program. And so one poignant example for me was that people were in a health policy and management, health services research Ph.D. program, and they specialized in an area like economics. So we had an opportunity, we had a health economics opening, and our very best student ever was graduating in health economics. And we wouldn't hire her because she wasn't a real economist. That, there is this sense that you have to be a purebred. You can't have been trained in a multidisciplinary program. And I think this is part of our academic snobbery, whatever issue with team science. And so it did make me think that, well, maybe we shouldn't be putting money into the pre-doctoral multidisciplinary programs. Maybe we should let people become a pure sociologist or a pure economist and then invest in the postdoctoral programs that train people to be multidisciplinary. So the crudest example I ever heard, I was visiting one university president, and he made this interesting comment. He said, you can't win a dog show with a mutt. And I thought, wow. But then I started thinking about it, and it is interesting because that everything we know about genetics, the mutt is stronger, they're more resistant to disease, they're a better dog, But people have this idea that you have to be a purebred economist or whatever, even though probably that cross-trained person will do the job better. And so we have to kind of realize where we are as an academic community and so forth. So I know I've been going on forever, so I'm going to, one more part of your question, then I'll get on to the next question. But that there is a lot of interest in early life at NIH, and it is across the institutes. And what we're seeing is in the neurosciences, there's all this work, starting with the Neurons to Neighborhoods report, but the realization that we are all of us are born with this remarkable complement of neurons and synapses, and that if we use them properly, they're exercised, then they stay, and if we don't use them, they get pruned. And so that if you look at the whole trajectory of how do you take a bite out of this problem, there is a sense that maybe those first few years of life are really where you've got a shot at it, and that you can do something. And so there is actually substantial investment across a lot of institutes in looking at this problem. Sure.
Other questions?
Yes.
Hi, thank you for a great presentation. So just a very quick comment that I'm a nutrition, and we've had a lot of people from other parts of the university come to work with us, so I feel like I've learned about team science by other people coming to us, and it has been wonderful. My main question is the behavioral science. What could we do as a group, because clearly there does need to be more postdoc support for that from one of your last slides?
Yeah.
What can we do to help support that?
Well, you have to let us know. It is important that you continue to raise these issues, because what happens, the decision making at an organization like the NIH is not shaped that much by the people inside. It's largely shaped by people who are on the outside, who are on advisory committees or members of stakeholder groups, and that sort of feedback, the drum roll is actually quite important. And I think that, I hope this message came through today, that the international report, although most of that's based on information that's been known for a while, really got my attention. It's a patriotic message that we do want to be, I don't know if we want to be number one, we want to be average. What do we have to do to get to be average? And that we are falling behind, and I believe that the report is pretty accurate, that mortality data is pretty reliable across countries, and that most of what you see driving that is not really the disease, although some of it is, but an awful lot of it is this behavioral stuff. Obesity, tobacco is maybe not as big of an issue, but it would be if it came up again. But injuries, motor vehicle crashes, a lot of things, poisonings, a lot of things that we have the potential to really do something about, and other countries have stepped ahead of us. And
I'll take the prerogative of the host and perhaps ask a question. I'm increasingly impressed by the sort of convergence of what we do know. You mentioned Halfman's work, Kurtzman's work. I would add Jim Heckman's work.
Of course.
To that in terms of the importance of these investments early in life. And I'm reminded of what we were told last week by a guest from the CDC who came up and talked a little bit about the importance of investments in school health. He said if you talk to people about it, policymakers, they basically nod, they agree, and nothing gets done. we've got decades of this work now that's converged about the critical importance of these investments, and yet we can't seem to get Congress, we can't seem to get policymakers to, legislate the investments that would really make a huge difference. So I'm kind of curious about what your take is about getting the science off the shelf, the fundamental knowledge that we're developing is the first part of that clause, to the application.
Well, I think it's crucially important, and again, as a federal employee, I'm restricted in what I can say about politics, so I have to sort of avoid the political side of it, except to say that it is interesting to see what's happened. So we have, as you know, in our country, this remarkable investment in medicine, and much more so. So we spend much more than any of the other countries, and we're below average in these health indicators. But what we've done, we've protected our medical investment, and that it's interesting to see what the opportunity cost of that protection is. I'll give you a really good example. My state, California. So I think many of you know, when I was a kid, California public schools were rated as the top in the country. We were number one, and now we're pretty close to the bottom. So we went pretty much from first to worst. And that when you look recently at this, when Medicare, from the Medicaid program kept getting more and more expensive. And so we protected medical care, medicine. And so that, in the Medicare program, Medicaid program in California is called Medi-Cal. So in order to keep enough money in Medi-Cal, they had to cut from somewhere. And guess where they cut from? They cut from education. But if you look at these analyses, if you believe the data, that you have much better health outcomes investing in education than you do investing in Medicaid. So let me show you one thing. I will show you one more slide, even though you didn't ask for it. That's the California. This is the California classroom size when they funded Medicaid, which went way up. This is really, this is a puzzling, complicated graph, but what this is this is total social expenditures in developed countries. So this looks at the Organization for Economic Cooperation and Development, and it looks at how much they're spending on social programs. And social programs are medicine plus education plus, other social services. So one of the issues is the United States here, we're about in the middle. A lot of people say we're spending too much. Actually, we're actually spending a lot less than these other countries. But what's interesting is that if you look at the ratio of how much we spend on medicine in relation to all other social services combined, the average in these countries, in all the other countries, is about 2 to 1. So if you take education, social service, social work, and all that stuff, they spend about $2 on that for each dollar they spend on medicine. The United States is really an outlier. It's 0.83. So we spend more on medicine than we spend on all these other social services together. And I think that's an issue. And that, I don't know if that gets directly at your issue, John, but I think it does say, we've been so enthralled by our expensive medical care system, which seems to be underperforming, that we've forgotten, or the opportunity cost is we've given up on some of these other services.
Yeah, and I think the challenge is, sort of the policy conversations, how do you shift that over time, particularly when you've got extremely vocal, strong political lobbies on behalf of medicine wanting to protect that, obviously.
Oh, absolutely, yeah.
And perhaps a weaker lobby on the side of education.
Yeah.
That hasn't been able to get full voice.
Yeah. So the Halfon argument, and this is Neil Halfon is my friend from UCLA, and he's been making this argument that I really kind of like. And what he argues is that, we built a healthcare system to deal with essentially acute illness. That the science of the day was the germ theory. And everybody believed that, death and disability was all about germs. Well, it turns out that science moved on beyond that. So then we had the Framingham study, risk factors, and so we had to rebuild the health system to deal with not only germs, but risk factors. And so instead of intervening when people were sick, you'd intervene when they started to develop high blood pressure, high cholesterol. And that's our current system. That's currently where we are. So, care moved out of hospitals into clinics. But his argument is, well, scientific thinking's moved on again. We used to think it was all germs. Then we thought it was, germs plus risk factors. Now we realize it's germs plus risk factors plus complexity plus social factors plus poverty plus all this other stuff. And the healthcare system isn't ready for that yet. So his argument is we don't need a healthcare system, we need a health system. So if we're interested in health, we have to connect hospitals and clinics and schools and come together under a completely new formulation that has as its goal, like the NIH goal, making people live longer, more productive lives.